Alright, this is going to be Pharmacology Module 4, Discussion 1. Discuss the difference in managing a postictal patient and a status epilepticus patient. A postictal patient has already finished seizing, they've stopped, and so they could be unconscious, they could be semi-conscious with an altered mental status, but they're going to be returning to normal consciousness, to a normal mental status. And so as far as managing a postictal patient, we got to verify the patient's airways clear, suction if we need to, if they're still unconscious, administer oxygen to help with the possible hypoxia because of not breathing during the seizure. We're going to gain IV access and check the blood glucose levels to see where they're at, to see if we need to administer glucose or anything like that. Keep the patient protected where they're at in case they do for some reason start to have another seizure, left side recumbent, and also monitor vitals, and then we're going to be transporting them at that point. Now, a status epilepticus patient means that when we arrive on scene, they're either going to start seizing immediately and they would already have come right off of another seizure, or they are going to still be seizing. So we're going to again move the patient, anything around them, to try to protect them. We're going to try to see if we can get an IV started of normal saline at a keep open rate. Monitor the cardiac rhythm if we can. With moving, that's going to be difficult. Get their pulse ox if we can again. Capnography if we can. Check their blood glucose again, and if they do show hypoglycemia, we're going to administer 25 grams of 50% dextrose, or 200. Well, that's probably what we're going to do. 250 mils a drop of D10 is not going to work well for. We want to get them that sugar quick to fix that issue. Or if it's not blood glucose, we'll administer 5 to 10 milligrams of Valium through the IV push slowly. We could use other benzodiazepine, but it just depends on what our protocol is. We'll continue to monitor the airway, which we would have done to begin with. Administer O2. Some patients may require more diazepam depending upon if they react to it initially. Then we're also going to want to have Flumazil, and I can't say it very well, but the antidote for the benzo in case they for some reason overdose and they have respiratory depression or anything like that. And so that's how, and then we transport, obviously, get them moving once we get them kind of under control, left side recumbent or just supine, depending upon how they react.